Welcome, everyone, to the TIMI Talks podcast. I'm Nick Marston here with my co-host David Berg, and on today's show, we'll be joined by our good friend, clinical trialist, and interventional cardiologist, Dr. Brian Bergmark, to discuss triglyceride lowering with ApoC3 inhibitors and results from the Bridge trial. Well, David, it's the end of another academic year and our final episode of Season 2 of TIMI Talks.
Yeah, that's right. And it's been a great season so far. We've covered a lot of different classes of novel therapies. So just as a refresher for all of our listeners, we covered GLP-1 RAs, we've covered LP-little-a inhibitors, we've covered factor 11 inhibitors. So a bunch of different types of agents in a rapidly evolving landscape within cardiovascular medicine. And of course, we already know that there's some big trials that are going to be reporting in the next season. So a lot of good material to come.
Absolutely. And we thought this would be a good opportunity to give a shout out to our graduating fellows here at TIMI. Our fellowship is a big part of the TIMI study group. David and I both went through it as well before coming on faculty. And we had 4 graduates this year. So a big congratulations to PK Gaba, Philippe Mora, Sid Patel, and Andre Zimmerman. It's been incredible working with all of you, and we look forward to seeing all the great things you guys accomplish in your career.
Yeah, the fellowship really is truly one of the best parts of being part of the TIMI study group. They bring so much energy, creative ideas, and it just creates an incredible learning environment for all of us. And this class was a particularly star-studded class. So we will miss all of you guys, but really looking forward to all of the great things you guys accomplish. But today we're going to be highlighting the work of another esteemed TIMI Fellowship graduate, Dr. Bergmark. And we're going to be talking about one of Nick's favorite topics in the world, lipid-lowering therapies.
That's right. Very exciting. A topic near and dear to my heart. Specifically, we'll be talking about triglyceride lowering therapies and some of the new targets. So maybe I can just set the stage with a little background.
Yeah, that would be great.
Sounds good. Well, I think the LDL story is kind of where the lipid world started, and we're all very familiar with that. We've got over 3 decades of outcomes trials showing that LDL is causal in cardiovascular disease, and we've got half a dozen great therapies for lowering it. Then we had HDL as a promising target, which just really unfortunately didn't pan out, either increasing HDL or improving its function, especially the CATP inhibitor class was a disappointment and kind of disproved the HDL hypothesis. And now really we're tackling the triglyceride hypothesis. Do triglycerides cause cardiovascular disease? Does reducing it reduce cardiovascular events? And that's really going to be the topic for today.
Yeah, I think that there's so much, I get so many questions about triglycerides and triglyceride-rich lipoproteins and sort of what's the implications with respect to cardiovascular disease and how do we reduce that risk. So I'll be honest today, it's an area that I think is still a bit of an open question. I wonder, Nick, could you tell us a little bit about what we've learned so far from other triglyceride-lowering agents?
Yeah, and it's always a little difficult to determine the role of triglycerides because it is so kind of wrapped up and entangled in LDL. Oftentimes patients have elevations in both, like a mixed dyslipidemia picture. Our therapies oftentimes lower both, typically LDL greater than triglycerides, but there is still some triglyceride lowering. So it can be difficult to tell what role triglycerides is kind of playing along the way. Nonetheless, we've got nice genetic analyses at this point, and they have demonstrated that triglyceride-rich lipoproteins, so namely like VLDL cholesterol, very low density lipoprotein, which like LDL carries an ApoB, is atherogenic. And so if we can lower triglycerides and VLDL enough, that should also lower ApoB, and then that should translate to a cardiovascular risk reduction. This lowering of both triglycerides and ApoB has been an issue in some recent triglyceride lowering trials. And so I think triglyceride lowering therapies have kind of gotten a bad rap lately. For example, the STRENGTH trial, which tested a combination of EPA and DHA, It lowered triglycerides by about 20%, but it did not lower ApoB, and therefore was a negative outcomes trial. Same with pemafibrate in the prominent trial, lowered triglycerides by 26%, but again, ApoB was not reduced, and another neutral outcomes trial. And so really, I think the key is to have a compound or drug that lowers triglycerides significantly, and with that, ApoB.
Yeah, I guess it all comes back to ApoB again, right? And so it sounds like what we really need is, as you said, an agent that reduces triglycerides, reduces triglyceride-rich lipoproteins, but also importantly reduces ApoB. So that I think sets the stage nicely for today's discussion, and particularly a couple new classes of agents or I should say, new targets that have been explored for the purposes of cardiovascular risk reduction.
Yeah, that's right. We've got two new genetically validated targets, and we know when our targets are genetically validated, they're much more likely to succeed in clinical trials. And those are ANGPTL3 and ApoC3, and we'll focus on ApoC3 today. But both of these proteins act to slow metabolism of triglyceride-rich lipoproteins like VLDL and also chylomicrons. And so this results in kind of a buildup of higher triglyceride concentrations in the bloodstream. And so the novel therapies that are being tested currently in phase 2 and phase 3 trials inhibit these two proteins, thereby increasing metabolism of triglyceride-rich lipoproteins and lowering their levels. And this is going to allow us really to test the triglyceride hypothesis once and for all and show us whether potent triglyceride lowering can reduce cardiovascular events independent of LDL lowering. So I think it's exciting not just for kind of the clinical application, but also for the science of it.
Yeah, and of course, though, before we can kind of get to the question of whether they reduce cardiovascular events, we really have to show that agents that are being developed that are targeting ANGPTL3 and ApoC3 are having the effects on the lipid parameters that we anticipate, right? And so
For sure.
that's where sort of these phase 2 trials come in, that to demonstrate the effects on lipid biomarkers.
Yep, absolutely.
So, so on that note, let's go ahead and bring on today's guest. So Dr. Bergmark is an interventional cardiologist at the Brigham. He's an investigator here at the TIMI study group, and he's an assistant professor of medicine at Harvard Medical School. His research interests include acute coronary syndromes, cardiometabolic disease, and complex coronary interventions. Notably, he was the principal investigator of the Translate TIMI 70 study, which was a trial of an ANGPTL3 inhibitor, vupanorsen, which he led along with you, Nick. And he's also was the principal investigator of the Bridge-TIMI 73A trial, which is a trial of ApoC3 inhibitor, the ApoC3 inhibitor olezarsen. And that's what we'll be talking about really mostly today. So without further delay, let's go ahead and bring our guest on the show.
Well, welcome to the podcast, Brian. It's great to finally have you on.
Thank you. Excited to be here with you guys.
Yeah, if we had a third co-host on the podcast, I think it'd almost certainly be you. So if this goes well today, you may be invited back.
Thank you, but there's a reason you don't have a third co-host.
Well, right, and that's because I think your interventional schedule is so tough to schedule around. So why don't you tell our audience a bit about your career and how you kind of balance both being an interventional cardiologist and a clinical trialist?
That's a generous interpretation. Yeah, I feel very fortunate to have sort of ended up in a spot where people have accommodated these two things on both fronts. And so I spend about half my time in the cath lab focused on complex and high-risk coronary interventions, and then the other half of my time here at TIMI doing clinical trials.
Yeah, and I mean, I think you have done an amazing job of balancing both of those. I always appreciate your insights as a trialist at the TIMI meetings, and of course appreciate your role as an interventionalist, a trusted both friend and colleague. So you've been able to navigate those worlds beautifully. But I don't want to give you too much credit in life, because don't want it to get to your head.
Sure. I wasn't paying attention the last 30 seconds anyway.
No, I'm kidding. No, you really have done a remarkable job. But one of the things that you've done a remarkable job on has been with clinical trials, and that's what we're here to talk about today, specifically the Bridge-TIMI 73A trial. And you and Nick really have been working on a number of trials in the triglyceride lowering space, including both ANGPTL3 and ApoC3 inhibitors, and obviously Bridge is focused on ApoC3 inhibition. And specifically the antisense oligonucleotide olezarsen. But before we dive into that and into olezarsen in particular, I guess it'd be helpful just to get your perspective on why we as a cardiovascular community should care about triglycerides and triglyceride-rich lipoproteins. And my disclaimer is that I'll be honest that when I'm talking with patients, I find that triglycerides and VLDL are the parts of the lipid panel that I still find most challenging to counsel around. So would love your sort of perspective on why should we care about this?
Well, first of all, I think you should interact more with unconscious patients. Than,
no, I do that a lot in this.
Yeah, you do quite a bit. So then stop checking lipid panels on your intubated patients. But I just have to say I'm quite self-conscious about how my audio quality is coming across to Allison Sow if she ends up listening to this. So
oh yes, shout out to Allison,
in the
friend
in
of
the
the pod.
Yeah. So obviously there are quite extensive data at this point about LDL and lowering LDL, reducing cardiovascular events, the biology, et cetera. And that's really the therapeutic focus, as you mentioned. There is the entire rest of this metabolic set of processes that are part of lipid metabolism and that get measured as other parts of the lipid panel and other things that aren't traditionally measured. And so among those are the triglyceride-rich lipoproteins. There are direct clinical consequences for patients who have severely elevated levels of triglycerides, meaning above 500 or 800 milligrams per deciliter with acute pancreatitis, which can be life-threatening. But for people outside of that sort of narrow top of the pyramid, there's a large group of people who have elevated levels of triglyceride-rich lipoproteins that contribute to their apolipoprotein B levels and we think cardiovascular risk epidemiologically from the biology of ApoB. And so there may be some cardiovascular benefit to reducing triglyceride-rich lipoproteins that could contribute to reducing residual risk even among patients who have had their LDL optimized.
Got it. Okay. So clearly there's some epidemiologic data there, and do we have any evidence, I guess, from other clinical trials that triglycerides is an important target, or do you think that that's still a bit of an open question?
So biologically, it would make sense that if you lower apolipoprotein B, including by lowering triglyceride-rich lipoproteins, that you should be able to reduce somebody's cardiovascular risk. Other therapies that have targeted triglyceride levels specifically have not shown a cardiovascular benefit, but they've also not lowered ApoB levels. And so with newer agents, like we'll talk about, there is the potential to lower triglyceride-rich lipoprotein levels while lowering ApoB in the process. And so while there are not trials to date of agents where the major mechanism is thought to be through the triglyceride lowering, showing a cardiovascular benefit. Obviously, icosapent ethyl is out there, but of sort of the entire reason for its benefit is not totally clear.
Right. Yeah. No, I think icosapent ethyl really put triglycerides on the map a bit, but it really does seem like the benefit there is maybe out of proportion to sort of what we saw with triglyceride lowering. So anyway, that's a great segue into sort of into olezarsen, and so we're going to talk a little bit about the olezarsen or to the Bridge trial in particular. But to get us started, I was hoping you might tell us a little bit about how olezarsen works. What does it do, and how does it actually lower triglycerides and triglyceride-rich lipoproteins?
Yeah, so a little bit funny to talk about this with Nick here.
You're the guest.
Because you guys are partners in crime. You guys are partners in crime.
So I'll just pretend I'm talking to you, Dave. No, but
You are.
honestly, just yeah, real pleasure to get to work on these trials with Nick, who, in addition to just being great in every way, is an absolute expert on these things. So there is this protein called lipoprotein lipase, LPL, and that hydrolyzes triglycerides and thereby facilitates the clearance of triglyceride-rich lipoproteins. And so then ApoC3, which is largely made in the liver, sits on these TRL particles and it inhibits LPL, so it prevents the breakdown of triglycerides and as a result leads to higher triglyceride levels. And so by inhibiting ApoC3, the result is that triglyceride levels are lowered and triglyceride-rich lipoproteins are cleared. There are also functions of ApoC3 outside of the LPL pathway that may be contributing as well.
Yeah, I think that's a good description, Brian, right? It's like it's an inhibitor of the we're inhibiting the inhibitor basically with olezarsen. So olezarsen kind of helps to lift the brakes that are on lipoprotein lipase, and then it can kind of freely hydrolyze these TG-rich lipoproteins like VLDL and chylomicrons. So, you had a busy spring. You presented the Bridge trial as a late breaker at ACC this year with simultaneous publication in the New England Journal of Medicine. So, huge congratulations for that. And it was an especially interesting trial because originally it was just kind of designed to provide additional safety data to support another trial, the Balance trial, which was familial chylomicronemia syndrome patients, which is a rare genetic condition, 1 or 2 per million who have a lot of pancreatitis starting in childhood throughout their life. A really important indication, but they're so rare that those trials are quite small, and so we needed to do another safety trial that was a bit larger. And that was Bridge. But really, after completing the trial, Bridge ended up having a much broader interest than I think initially planned, given the population that we studied. So, can you talk a bit about the design and population of the Bridge trial?
Yes, so the Bridge trial, as you said, is intended to look at a broad population of patients with hypertriglyceridemia, and with the notion in mind that it's a group of people who might be studied for cardiovascular risk reduction in the future to understand how the drug works in terms of efficacy and safety in this type of population. And so the patients had moderate hypertriglyceridemia plus elevated cardiovascular risk. So that's a level from 150 to under 500 milligrams per deciliter, or had severe hypertriglyceridemia independent of cardiovascular risk. So a level of at least 500. And these patients were randomized to one of two cohorts, a 50 milligram cohort or an 80 milligram cohort, so that these two dosing regimens could be understood. And then within each cohort, they were randomized 3-to-1 to olezarsen, given monthly subcutaneously, or to placebo in matching volume. And so they were treated for a year. The primary endpoint was the change in triglycerides at 6 months. And then we looked at a whole lot of other secondary endpoints, including the impact on ApoC3, ApoB, non-HDL cholesterol, changes at 12 months, et cetera. And then, of course, safety.
And so, do you want to tell us what you guys found? And I guess one of the things to sort of that I'd hope you addressed is sort of what you learned about the two different doses. Were there important differences between the two doses that you saw?
So the drug worked. So that was good.
Spoiler alert.
Yeah. So the reductions in triglycerides at 6 months were about 50%. A little bit more with the 80 milligram dose, 53%. This is compared to placebo, 49% with the 50 milligram group, and then sustained effects out to 12 months. Importantly, when we look at the impacts on the rest of the lipid parameters, apolipoprotein B was reduced by about 18 to 19% by the two doses as compared to placebo. non-HDL cholesterol by about 24-25%. And then there was no difference in LDL compared to placebo, no change significant compared to placebo. And so those changes suggest the potential for a cardiovascular benefit.
Great.
Right.
We'll
So
get
it
into
goes
that.
back to your,
Sorry,
go ahead,
go ahead.
Nick, sorry. No, I was just going to say it sort of goes back to the point that you were making at the beginning that it was a robust triglyceride lowering agent, but there was these other lipid parameters that also improved that potentially speak to its benefit as in terms of cardiovascular risk reduction.
Exactly.
Yeah, it's an important topic.
And then I
And we'll,
guess
oh, sorry.
okay. Sorry, Nick.
We're
Go
so
ahead.
excited to talk to Brian, you know.
I know.
All right, raise your hand in the chat.
No, I was just going to ask. You spoke to that basically there was sort of minimal differences in terms of magnitude of triglyceride lowering between the two doses. Any sort of thoughts about why that's the case? Does it seem like is your interpretation of that it's sort of a threshold issue, or how do you sort of make sense of the dose ranging or dose finding aspect of the study?
Yeah, they were pretty similar. You know, for most of these parameters, you get a little bit more horsepower with the 80 milligrams. I think overall, probably more favorable. We'll talk about safety in a moment, but nothing that stands out with the 80 specifically as compared to the 50. You know, so right, it appears between 50 and 80, there's not some major threshold that's been crossed, but all in all, maybe slightly more impact with the 80.
Got it.
We'll of course get a lot more data from the ongoing trials.
Great, and I want to talk about those for sure because I think the ongoing trials are going to help answer some of the questions that remain after Bridge. But just kind of finishing up with Bridge, obviously safety, a key part of this phase 2 supportive trial, especially considering that the parent compound volanesorsen had issues with thrombocytopenia, which led to it not being approved for FCS in the US. However, it is approved in Europe for FCS patients. So obviously thrombocytopenia is something we're watching for carefully here. And then also, you know, given the antisense ANGPTL3 trial we did, Translate, looking at vupanorsen in a similar population, that had a signal for increased hepatic fat measured by MRI. So Brian, I want to ask how you thought the safety profile kind of compared for olezarsen and Bridge, and perhaps share with our listeners a bit about the ongoing MRI sub-study.
Thanks. So it brings up a few important points. As you mentioned, there were specific concerns for the parent compound that were of particular interest. So from a renal function perspective, and I guess I should say we anticipated to be less relevant for this later generation version of the compound targeted specifically to the liver. But so from a renal perspective, things look good. For very minor reductions in platelet count, you know, perhaps a bit more of that, but in terms of meaningful platelet count reductions, nothing stood out. And then for the liver enzymes, for low-level elevations in ALT and AST, they were more common with olezarsen than with placebo, but meaningful increases in ALT and AST, meaning of at least 3 times the upper limit of normal, were quite rare with no difference across treatment arms. So it'll be important to watch in the future, but nothing here stood out as a major concern. And so then, as you mentioned, for drugs targeting this pathway generally, including those for angiopoietin-like 3, there are biological reasons, preclinical data, to think that this could be a way to reduce hepatic fat. And so that was something that we had looked at in the Translate trial, and unexpectedly there was an increase in hepatic fat by MRI with vupanorsen. Here we, you know, through the similar related pathways, would anticipate that there could be a reduction in hepatic fat, and that has in fact been seen in aggregate across smaller studies with the parent compound. volanesorsen. And so this is being studied specifically, as you know, in the CORE and CORE2 trials for patients with severe hypertriglyceridemia, where there is a hepatic MRI at baseline and then at 12 months to assess for an impact on hepatic fat content.
So great. I mean, I guess we learned drug works. We learned that there's no major safety signals at this point. More data to come. I think that sounds like those are the key take homes. And then Nick also mentioned the Balance trial, which was presented at ACC as well, which was the study of olezarsen in FCS. And so is there anything else that we learned about olezarsen in that trial? And how do you see those results supporting or complementing or intersecting with the results of Bridge? And how does that inform ongoing studies and impact practice?
The Balance trial is quite promising. That was in patients with specifically familial chylomicronemia syndrome. And so it's a somewhat different population in that they have an inherited syndrome impacting LPL, and so you don't expect the exact same impact on triglyceride levels, for instance. But this is a group of patients who are quite severely impacted clinically by their quite elevated triglyceride levels. There, I think the baseline levels were north of 2,000. And it's a group of patients really at risk for pancreatitis, and the olezarsen nearly eliminated pancreatitis events in those patients as compared to placebo. So really striking clinical importance for the drug in that high risk population.
Yeah, and it's I mean, it's rare, but it's such a impactful condition. I have a couple of these patients in my clinic, and they were diagnosed one as young as 2 years old, and having, recurrent pancreatitis throughout their lifetime, and just really any kind of subtle change in diet or any amount of alcohol could tip them over and put them in the hospital. So I think olezarsen looks like it's going to be a game changer in that select group of patients, for sure, the FCS patients, and the FDA filing, I think, is underway. So that's super exciting that is coming in the near future. But then, looking at the broader population, so below FCS, then we have severe hypertriglyceridemia. These are patients with TGs 500 or above. So we're studying those in CORE and CORE2 right now, and it's another group at risk of pancreatitis. So hopefully this drug lowers pancreatitis there as well. We will see. And then you've already talked a lot about this much broader population, moderate HTG. This is a group not at risk for pancreatitis, but perhaps there is risk of cardiovascular disease. You've already talked about ApoB and the importance of lowering atherogenic particles, not just triglycerides alone, but you have to kind of also lower ApoB. So kind of given all this and what you know so far, do you think olezarsen has the potential to reduce cardiovascular events, and what are the next steps in this moderate HTG population to kind of demonstrate that may be the case?
The biology certainly suggests that it should. In terms of what's understood about these pathways, as you said, atherogenic particles as measured by ApoB, genetics. There are a couple issues. One, life doesn't always follow the rules. And then two, there's always a question of magnitude. And how would you show something, even if you think it might be true? And what size and duration of trial would be needed to actually demonstrate that? And is that actually going to happen? And so as an intermediate way of evaluating this, the Essence trial of over 1,300 patients with a similar population to the Bridge trial includes, at your urging, Nick, as you know, a coronary CTA substudy where patients are getting coronary CTA at baseline as well as at 12 months. And so I think this can provide a helpful surrogate to understand if there appears to be a biological impact on plaque volume with with olezarsen. Certainly, if that showed something meaningful paired with the laboratory data we have, I think that would be a quite compelling motivation to test the drug in an outcomes trial.
Yeah, I mean that would be awesome. Fingers crossed for Essence and sort of what's to come with the coronary sub study. I think part of this discussion is not just focusing on olezarsen, but just on this class of agents and what's in the pipeline. And so we should definitely mention that there's an siRNA targeting ApoC3, plozasiran. I don't know if I said that right, but that's one of those like you read. You read it and you're not sure exactly how it's supposed to come out, but I guess that was appropriate feedback.
Yeah, thanks for falling on that sword.
No problem. So there was also a moderate hypertriglyceridemia trial with that agent, the MUIR trial, that was just presented at EAS and simultaneously published in the New England Journal of Medicine. So now we have two similar agents, similar trials, and two recent publications. What are the key differences between those compounds and their effect? Or are there key differences between those compounds? And what should we know as we're looking forward to what's to come from these two agents?
You would expect them to have quite similar effects, given that they are doing essentially the same thing. Obviously, the dosing is different, and in fact, several doses were studied, but broadly speaking, the degree of ApoC3 inhibition, the degree of triglyceride lowering, was similar in this similar population. And so, they're sort of lining up more or less as you would think. There are sort of particulars to the different trials. There has been a signal of worsened glycemia with that agent across a couple trials now. So that's something that's being dug into a bit more to understand why that's happening. But broadly speaking, in terms of the impact on the target and the impact on the triglycerides, which was the primary endpoint, similar to olezarsen.
Got it.
Well, Brian, this has been an excellent discussion, and I think at the beginning of the year, I said that this was going to be one of my top 3 kind of areas to watch in cardiology, and here we've already seen so much come out in the first half of the year. Obviously, a lot of ongoing studies to come, so we'll certainly cover those when the time is right. And I think you're at risk of being asked back onto the show given your performance here today. So, but before we let you go, we would love to see if you have any parting words of advice for our early career listeners who are interested in trials, especially those who may be wanting to also go into procedural specialty.
Not really, but I will. But first, I came prepared. So I have a short story about David Berg. So when I was in college, and also my wife, we were in the same class as David Berg, who always knew more than everybody about everything. And in particular, there was one class called Humans and Viruses, where our professor, Bob Siegel, would ask the most esoteric questions to the group, expecting everybody to know starting on day one. And he would go down the group and expect somebody to know for a virus family, like the nucleic acid format and the capsid morphology and what and you'd go down the row, and he'd just get more and more disappointed as nobody knew. And then eventually he'd get to David Berg, and Dave would always know the answer. And so then he would like rescue us from this situation where like 150 of us are being embarrassed. And so I thought, actually, Regan and I we just saw Bob Siegel actually.
Oh, really?
A walk in the woods and had us eat wild gooseberries and stuff. But it inspired me to see how much of this Dave remembers.
Oh God! Oh God! The answer is zero.
I have printed out a chapter in a book called Classification of Human Viruses, written by Bob Siegel. All right, so Dave, we'll start with adenoviridae. Do you recall the nucleic acid?
I think it's DNA, but
My God, yes. Okay.
That was too quick.
Capsid morphology.
I forget.
I'll give you. You can choose between helical and icosahedral.
Let's go with icosahedral.
Yeah, that's correct. Wow. All right. We're gonna push it. We'll do one more. We'll do Bunyaviridae.
I do remember that discussion. That was a lively lecture and discussion, but really you're starting to tax the sort of the far reaches of my memory.
All right. Well, nucleic acid. I mean, there are only so many guesses here.
Let's go RNA.
All right. Done. That's it. All right.
Wow.
And then capsid morphology.
Let's go helical.
That's right. And then finally, just to wrap it up, because we can't let you leave on 100%. Enveloped, yes or no?
Bunya or adena?
Bunya.
I'm gonna say enveloped.
God.
Wow.
Probably not supposed to swear on this podcast. That was it.
All right. Well, give Bob a hug. I guess you just saw him, so you won't see him again. But I'll have to tell him that I did him proud.
Oh, I will send him the podcast.
Thank you for continuing the tradition of grilling Berg on this podcast. It continues to be 100% correct.
Yeah. Oh, God. All right. Well, in any case, that was disappointing. So,
well, Brian.
Yeah.
Before I let you, actually, I'm going to just have to cut you off before you, because I'm riding the high of my old humans and viruses days. No, I'm teasing, but it really has been awesome knowing you for so long. I'm glad you took us all the way back to college, and have always counted you as a dear friend and colleague, and somebody whose opinion and sort of thoughts about clinical trials and cardiovascular disease I care deeply about. So thank you for being an inspiration. Thanks for coming on the podcast, and thanks for sort of sharing a bit of your personality to all of the viewers out there who may be impressed by you but may not realize just how amazing you are. So thanks for coming on the show.
That's very kind. Obviously, ditto. This has been a lot of fun, guys. I really appreciate it, and working with you every day.
Thanks, Brian.
Thanks so much,
this was
Brian.
awesome. See you for lunch tomorrow.
Well, that was a great discussion on ApoC3 and olezarsen, and I love that it was chock full of the Bergmark flair.
Absolutely.
And of course, there'll be a lot more coming from the TIMI study group on ApoC3 inhibition and olezarsen in particular, which Nick, you'll be telling us a lot more about on the next season. So if you enjoyed that discussion and love lipid-lowering therapies, definitely stay tuned. Much more to come. And we'll be picking back up the TIMI Talks next season on TIMI Talks after ESC. So have a great summer. And until next time, for the TIMI Talks podcast, this is David and Nick signing off.
Thanks for listening. The TIMI Talks podcast is hosted by Dr. David Berg and Dr. Nick Marston and produced by Kate Brennan. Like and follow us on Apple Podcasts, Spotify, and Google Podcasts, and follow us on LinkedIn and X @TIMI Study Group to be informed about podcast news and upcoming episodes.